The following podcast is part of a certified educational activity titled Tailwinds of Innovation in Small Cell Lung Cancer, exploring the therapeutic potential of ADCs. Access the entire activity and complete the post-test at peerview.com/XDB860. Downloadable slides and practice aids are also available.
Hi, I'm Dr. Jacob Sands, thoracic medical oncologist at Dana-Farber Cancer Institute, and I'm excited to talk with you today about tailwinds of innovation in small cell lung cancer, exploring the therapeutic potential of ADCs. This is an exciting new class of drugs to the lung cancer space, and we're going to go through ADCs specifically focused on small cell lung cancer. Now, our goals for today are to enhance the understanding of the rationale for use of ADCs in the treatment of small cell lung cancer, and to augment your knowledge of the latest evidence supporting the use of ADCs in small cell lung cancer. First of all, there are an array of antibody-drug conjugates at this point, and we're going to focus on those specifically related to small cell lung cancer. But briefly to mention, antibody-drug conjugates have three components. There's an antibody that binds to a specific receptor and a linker that holds a payload. Now, in all of these cases, the payload we're going to be discussing is a cytotoxic of some kind. And we're really in the era that I would call first generation ADCs, but that payload could end up being some other kind of compound or some other kind of therapy, such as a form of immunotherapy. But right now, we're talking about antibodies that are holding payloads of cytotoxic therapy. Now, the antibodies bind to the surface, they're pulled into the cell, and then the lysosome releases that payload. And so it's a way of delivering chemotherapy intracellular to the tumor cells, where it then has treatment effect and kills the tumor cells, spilling the contents out. And when those payloads are also membrane permeable, then we call that a bystander effect, where that payload, that chemo, can then cross membranes into surrounding cells and have that same cytotoxic effect. This really enables the delivery of chemotherapy to each of these cells within the tumor environment, even if not all of the cells express the specific receptor that we're targeting. Now, on the right side, you see the different receptors there, starting with DLL3 and Rovati. Now, this was unfortunately a drug that did not ultimately get moved along. This was, as we say, a failed drug, but it did demonstrate DLL3 as a receptor in kind of a proof of principle, and that has led to many different other treatments that now target DLL3. And recently, and most relevant, is an FDA-approved immunotherapy in tarlatamab. But Rovati was an antibody-drug conjugate. There are other antibody-drug conjugates to DLL3 in development. You see CD56, TROP2, which we will discuss a bit, with sacituzumab govitecan, B7H3. We'll discuss DS7300, or now Ifinatamab deruxtecan. That is one of multiple now in the B7H3 space. And SEZ6 with ABBV. Here's 011. That's a prior one. We're going to be discussing ABBV 706. Now, to start out with Ifinatamab deruxtecan, this is the B7H3 antibody-drug conjugate, has, as an ADC, has the components that I've described. The payload is a topoisomerase inhibitor payload. It does have a bystander effect. The deruxtecan is an exatecan derivative that has a bystander effect, as I've described. In this case, the drug-to-antibody ratio is about 4. The payload deruxtecan is a highly potent payload with a short systemic half-life. The linker is a stable linker, and there's always a balance with the linker in wanting to hold the payload until it gets delivered to the specific tumor environment, but also then being able to release it when there. And there's a lot of technology around the linker that we're not diving into as much today, but that is the balance in that. And at this point, I think one of the most nuanced parts of creating an antibody-drug conjugate is to have a linker that is holding the payload for exactly the time that's wanted. As you see on the bottom part there, the bystander anti-tumor effect, as I've described. Now, what we've seen from Ifinatamab deruxtecan, this is looking at initial phase 1 dose escalation, escalating up from a starting dose of 0.8 milligrams per kilogram, and this went up to 16. This led to the next trial that we'll look at, which was an 8 as compared to 12 milligram per kilogram dose level. So the initial phase 1 being a dose finding. In these phase 1s, typically the primary endpoint is really more around tolerable dose and AEs related to the therapy. And here we see the J101, again at the multiple different dose levels. In this case, looking at the efficacy from doses of 6.48, 12, and 16 milligrams per kilogram. On the right side, you see the overall response rate was about 53%, with 10 PRs and 1 CR. The median duration of response being about 6 months, and the median progression-free survival being 5.6 months, median overall survival 12.2 months. And you can see the patient population had a median number of 2 prior lines of therapy. Now, B7H3 itself, the expression, has not really been an indicator of whether or not we'll see response. And so with varying B7H3 expression, you see that there was 1 CR, multiple PRs, some stable disease, progressive disease, and without a clear pattern to this. So B7H3 expression by IHC is not really an indicator to guide us on who to treat. Here is the J101 overall safety summary, and you can see that there was more than just small cell lung cancer enrolled. There were other tumor types. On the far right there being next to the total is the squamous cell non-small cell lung cancer. And the median duration of treatment was longest on small cell lung cancer, which is quite a statement considering small cell is maybe the more difficult to treat and the more aggressive of these other tumor types. Patients generally tolerated treatment fairly well, although there certainly were some drug discontinuations due to treatment emergent adverse events. And you can see 5 or 22.75% in the small cell lung cancer cohort. Now, this led to the 8 versus 12 mg per kg dosing that I had described. And from that, we see these waterfall plots, which is really encouraging to see so many of the patients enrolled to have some degree of tumor shrinkage. Now, what met 30% varied. And so in the 8 mg per kg dosing, we see a response rate of 26%. In the 12 mg per kg dosing, about 55%. 55% response rate in previously treated small cell lung cancer is an impressive number. Now, this you can see the disease control rate was even higher, so stable disease seen with small cell lung cancer. Now that gets to 80% of patients in the 8 mg per kg dosing and about 90% in the 12 mg per kg dosing. Here are the spider plots, and you can see that there are a number of patients with some durability to this as well, with these spider plots extending out some of these responders out even beyond a year. Here are the progression-free survival curves on the left and overall survival curves on the right. And somewhat similar, the median progression-free survival with the 12 mg per kg dose was 5.5 months and overall survival 11.8 months. And this is the dose that has been carried forward. Here we see efficacy summary in patients with brain metastases at baseline. So that's not necessarily to say response in the brain. You see this is systemic response on the left and in the middle, and on the right is intracranial response. And we do see about a third of patients having some intracranial response, which we've certainly seen from the deruxtecan payload across other studies as well. Now, if we focus on intracranial response in patients with baseline brain metastases, you can see at the 8 and 12 mg per kg dosing. On the left there is patients with brain metastases at baseline, 37% with a confirmed response, 39% in the 12 mg per kg with confirmed response. On the right is subset of patients with brain target lesions, and here we see a higher percentage. But again, we are looking at lower numbers. The deruxtecan payload has demonstrated responses in low numbers across all of the different studies that incorporate it as the payload for the ADC. And so to see some responses is consistent with what we've seen from other trials. From a safety summary, we see a median treatment duration of 3.5 months on the 8 mg per kg dose, 4.7 months on the 12 mg per kg dose, which again is the dose that has gone forward for further study. We see 17% of patients that did end up with drug discontinuation due to treatment emergent adverse events within that 12 mg per kg dosing. Here's the toxicity tornado plot. And you can see overwhelmingly this is grade 1-2, but there certainly are some toxicities to be aware of at this dosing, especially the 12 mg per kg dose on the right. Nausea, decreased appetite, and anemia being among the top 3. Now, there's an ongoing trial of ID8-Lung02. This is second-line treatment. So after prior platinum-based therapy, patients get randomized to I-DXd or the treating physician's choice of either topotecan, amrubicin, or lurbinectedin. This has a dual primary endpoint of response rate per RECIST by BICR and overall survival. Now, another antibody-drug conjugate for SEZ6 is ABBV-706. You can see this is low numbers at multiple dose levels, but this waterfall plot looks very impressive with almost all of them representing some degree of tumor shrinkage. There was a 61% response rate noted in this. Those were all partial responses, and another 30% with stable disease. When looking at the toxicity profile, the cytopenias stand out, but as well as fatigue being the most common. And there were 77% of at least grade 3 treatment emergent adverse events, 57% experiencing some dose interruption, 38% dose reduction, but only 4% leading to discontinuation. Now, TROP2 expression is another target that we're going to discuss. And interestingly, TROP2 expression is considered to be a poor prognostic marker in non-small cell lung cancer. Here you see a slide referencing a publication that included a cohort of high-grade neuroendocrine tumors. Many of these were small cell lung cancer, but not all of them. And you can see that in small cell, TROP2 expression does not necessarily represent as poor prognostic marker as what we see with non-small cell, and maybe actually the reverse to some degree. There's still a lot for us to learn about TROP2 expression. Now, sacituzumab govitecan is an antibody-drug conjugate that targets TROP2. Here's a study including 62 patients with small cell lung cancer, showed an 18% response rate and a median duration of response of 5.7 months. Median progression-free survival was 3.7 months, and median overall survival 7.1 months. Looking further at this, we see the median time to response was 2 months. There were 2 PRs still going at 7.2 months or longer and 8.7 months or longer after the sacituzumab govitecan initiation. Stable disease was the best response in 42% of patients. Now, small cell lung cancer tends to be a rapidly progressive disease, so stable disease showing up. There's certainly some of those patients that are benefiting, and it's hard to know the exact numbers, but just represents some degree of the stable disease getting clinical benefit. Now, sacituzumab govitecan is a second-line treatment for small cell lung cancer. has shown a response rate of about 42%, with duration of response rate at 6 months being 48%, median progression-free survival of 4.4 months, and median overall survival of 13.6 months. This has been seen in both platinum-resistant and platinum-sensitive disease. Not surprisingly, we see a higher percentage of responses in those with platinum-sensitive disease, and often say that platinum-sensitive represents cytotoxic sensitive. Now, the antibody-drug conjugates may be a way to overcome some of the platinum resistance that's noted, given the higher concentration of chemotherapy delivered to the tumor. But when we see platinum sensitive, which again is cytotoxic sensitive, that does suggest that cytotoxics are going to have more of an effect than what we see in those with a shorter chemotherapy interval or more platinum resistance. Now, the safety profile of sacituzumab govitecan was common with what we've seen in other studies, namely most common being neutropenia and diarrhea. And so these encouraging data do warrant further study, and there are studies ongoing. In conclusion, we have an exciting new class of drugs and antibody-drug conjugates that are being used now for small cell lung cancer. We've gone through a few of the multiple antibody-drug conjugates currently being evaluated in clinical trials. In a tumor without easily targetable mutations, targeting surface proteins with antibody-drug conjugates is an attractive approach, and preliminary results are promising. We need to determine the best characteristics of antibody-drug conjugates and how to direct them to small cell lung cancer for a greater effect. It is important to recognize and manage antibody-drug conjugate toxicities, some of the unique ones for each of the drugs, as well as common ones that we see across different antibody-drug conjugates. It is exciting to see this class of drug have efficacy and tolerability, and adds to the armamentarium of our treatment options for small cell lung cancer. Thank you so much for your attention today.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Daiichi Sankyo Incorporated. To access all materials for this activity, visit peerview.com/XDB860.